I'm your host, Dr. Mohammed Afsal.
I'm Dr. Vivek Verma. We can do limb-saving surgeries in bone cancer in more than 95% of the cases. So, in biological reconstruction, we use living tissues from the body parts or somewhere, and we reimplant in that position to restore that function, to restore that body part. So, it's using a living tissue.
It sounds straight out of a James Cameron movie. Taking out the bone, dipping it in liquid nitrogen, putting it back, and at minus 190 degree.
Once we reimplant this in its position, this restores the blood supply, the vascularity. So this bone regrows.
But someone might argue, like if amputation can remove the whole cancer and treat it, why keeping the limb? Does it give more chance for the cancer to regrow? So how do you tackle that question?
Whether you do amputation or you do the limb salvage surgery, the local recurrence risks are same. With cryotherapy, probably by 4 to 6 months, my patients are almost walking normally without any support. In the word cancer, first part is can. There is also can. So that is where you can win. So remember that we can win over cancer.
Welcome all to the Bluedot Podcast. I'm your host, Dr. Mohammed Afsal, Medical Director and Flight Physician for Bluedot Air Ambulance and Bluedot Medical Assistance. Here we talk about the current updates in the field of healthcare and medicine, the latest innovations and technology, the future innovations and beyond. In this episode, we are going to talk about a sci-fi movie stuff. What if I told you that today, in an operation theater in India, surgeons are removing bone from a patient, freezing it in liquid nitrogen, kill the cancer cells, and putting it back in the patient? What if I told you that teenage patients with bone cancer can save their limb rather than facing an amputation? That biological reconstruction techniques are helping patients regrow their own bone. This is the reality of the modern orthopedic oncology, and today we have with us one of the leading experts in this field of orthopedic oncology, Dr. Vivek Verma from Max Healthcare, Vaishali. Dr. Verma, welcome to our podcast.
Thank you, Dr. Afsal, for this invitation. I'm Dr. Vivek Verma. I head the Orthopedic Oncology and Reconstructive Surgery Department at Max Healthcare, Vaishali and Patparganj unit in Delhi, NCR. So I'm primarily orthopedic surgeon, and I was trained at Chennai in orthopedics, and then my super specialty training in orthopedic oncology from Tata Cancer Hospital, Mumbai. I was also trained in complex trauma and joint replacements from Germany. Now I head this department here for last almost 10 years, and I'm sure that the way that we are going to discuss today, we are going to touch new dimensions in the treatment of bone and soft tissue cancers.
Absolutely, Dr. Verma. So let's start with the fundamentals. The
Yes.
term ortho-oncology.
Yeah.
I'm so sure it is not just orthopedics plus cancer just mixed together. So could you please explain this unique specialty of yours in a much better way?
Right. So, when I was doing my orthopedic training, we used to treat patients even with cancer. And then one of the surgical oncologists there, he told me that oncology is a totally different ball game. It's not like doing a routine joint replacement or doing trauma where you go and fix the bone. So in cancer, there are different principles. So when I went for my training in oncology, then I realized that you need special training to handle these cancer cases.
Yes,
That's the reason worldwide people say, those who are not into oncology, they say the results are poor. Because unless the cancer, especially this specialty, is addressed by a person who is trained into this technique and how to manage these cases, the results are not going to be good. We really need to be well versed with the principles of treating bone cancer, removing it properly so that the recurrence risk, the success rates, everything gives you the best outcomes.
So, doctor, when a patient comes to you with a persistent bone pain, what are the red flags that differentiates with bone cancer and with the regular arthritis or injury for that matter?
So that's a very good question, because majority of the cases who come to me for opinion, and when I look at their history, I find that a minimum of 3 to 4 months has elapsed since they had their first symptoms. So people always think it is just normal bone pain, because if the child is growing, it may be just because of over sports or exertional injury. In old age, people think of like arthritis. But I will tell you three signs or three symptoms which is very crucial to know and should be evaluated. We should not ignore them.
Okay.
Now, number one is swelling. Now, many people may have swelling in their body here and there. That's normal. But any swelling which is more than 3 centimeter in size, whether painful or painless, but if it is growing in size more than 3 centimeter and deeply situated, it should be evaluated. So not saying that this may be cancer only. It may be a benign lesion. It may be, say, a fatty tumor like lipoma, anything. But if it is more than 3 centimeter, it's increasing in size. It is showing change in its behavior, like it was painless before, has become painful now. It should be evaluated. Now, this is the first symptom. The second symptom is for pain. Like, everybody must have faced pain in their bones and joints. So which type of pain? That is important. So any pain which is persistent, recurs after taking analgesics, which means painkillers, or the pain which wakes you up at night from sleep, that is something which needs to be evaluated. Now, like I said, not necessarily that the underlying cause may be cancer. There may be different causes like osteoporosis, arthritis, infection, which is the most common, the second diagnosis in these cases. But the pain which wakes you up at night, which is present at rest, should be evaluated.
Of course, yes.
And the third and the last is pathological fractures. Normally, our bones do not fracture unless there is a significant impact of trauma. But if the bone is fractured with simple injury like fall at home, we need to evaluate it. So it may be because of osteoporosis or other reasons, but it shows that there is some pathological condition underlying. So we need to evaluate what is the cause. So quickly summarize: swelling, which is increasing, changing its behavior; pain, which wakes you up at night; and third, a pathological fracture, which happens due to a simple injury. Please evaluate, go to the specialist.
Yes, of course. So the symptoms are like clear. And yes, it's true that we are seeing more young adults and even children increase in the number of bone cancer cases. Is it just a true increase or rather a better detection with advanced imaging? What do you think about it?
So I feel it's both ways. Nowadays, we have all the tools to pick up the disease early. We have MRI, high quality MRI, 3 Tesla MRI,
yes.
PET scan, and other tools. But in my experience, I'm seeing that globally, there is overall increase in this incidence rate, which means new cases are becoming more and more higher. So both things are there. The number of cases are also increasing, and we are able to pick them up early with better tools.
Diagnostics. So talking about the diagnostics, there's this persistent myth about biopsy. People say that this biopsy can awaken the cancer or even spread it.
Yeah.
So as a person who does this on a daily basis, what is your take on that?
So I think this is the most favorite question of the patient, because when looking at the X-ray or MRI, when I ask them that you need to get a biopsy done, the next thing they say is, doctor, this is still dormant. Why we want to touch it? It will grow. So this is a myth. The fact is, biopsy is very critical in establishing the diagnosis, what we want to do. Now, people always feel that their tumor has started growing after the biopsy. This is also a truth. But this is not because of the biopsy. The tumor has the tendency to grow. When the patient comes to us, already it has, say, increased the size of 4 or 5 centimeter. So it is a doubling time. Whether or not we do the biopsy, it is going to double in the next few days or few months. So it's just a coincidence that it increases. Now, second part, which is very important, especially in developing countries or where the healthcare facilities are not there. Biopsy should be done by the specialist. This is very critical. If it is done by somebody who is not trained in dealing with these cancer, then of course, if it is not done properly, the cancer will tend to spread. So it should be ideally done by the specialist.
Great. Okay, that's clear, doctor. So let's tackle a tough question.
Yeah.
In this advanced era of advanced imaging and radiology, can we ever skip a biopsy and go straight to the treatment?
Very good question. And yes, we can, because there are certain type of tumors which, let us talk about bone tumors specifically, which we can diagnose with pretty certainty that yes, this is the characteristics based on X-ray or MRI looks like a benign type of tumor. For example, sometimes we may have bony overgrowths, which is called exostosis or osteochondroma, which many people may grow in their legs. Lipoma. So we look at the imaging, and another important part is to correlate it clinically. We should also take the history, how it is behaving. If your clinical correlation and your imaging tool are very characteristic of a particular diagnosis, and it's a benign tumor, we can skip a biopsy. But if any doubt, biopsy is almost essential.
Okay, great. So talking about bone cancers, one of the big fears that everyone has is, I like to call it the amputation myth.
Yeah.
So bone cancers automatically means amputation. So let's shatter this myth once and for all.
Just to summarize in one line, I'll say in today's era, now we are talking 2025, we can do limb-saving surgeries in bone cancer in more than 95% of the cases. So current standard is not the amputation. The current standard is to do a limb-saving surgery. Limb-saving surgery is a procedure by which we save the limb while we remove the cancer completely with the aim to cure the disease.
Yes,
and patient can go back to their function, their outcomes are good immediately.
Okay. But someone might argue, like, if amputation can remove the whole cancer and treat it, why keeping the limb? Does it give more chance for the cancer to regrow? So how do you tackle that question?
Yeah, so if you look at it from a common sense and the logic, that if you're preserving the limb, if there is a cancer in some part of the body, say in hand, and if you remove that part, then should the risk of recurrence is higher? That is, most people ask. So let me tell you, this is because, and this is not my experience, I'm talking from something which is evidence-based globally at all the cancer centers across the world. It has been proven that if the cancer is removed with wide margins, which means it's called R0. Zero means it is completely out. You're not leaving anything inside with proper margins. Then whether you do amputation or you do the limb salvage surgery, the local recurrence risks are same. It's not going to change. So I think the crux here is, the most important point is that it should be removed by the specialist who is trained to do these surgeries, who can remove the tumor, who can remove the cancer completely out of the body with wide margins.
Okay, that's understood. So, as seen from your profile, I've seen this biological reconstruction and your work on that is groundbreaking. So, what exactly is it, and how is it different from this conventional tumor reconstruction surgeries?
So this is a very interesting part, because there's something which is new, and biological reconstruction. Let me just break this question into 2 or 3 points.
Okay.
So let us first understand, how do we do a limb-saving surgery, so that we can understand what is biological and what is the conventional way.
Yes.
So limb-saving surgery is where we remove the cancerous part from the body. We reconstruct this part again by different techniques, so that the patient can be back to normal with the aim to cure the disease.
Yes, that's right.
Now, the conventional way was the way I was trained initially. So I have experience of around 17 years in this field. So the conventional way was to use a mega prosthesis, which is a tumor prosthesis. It is something which is beyond routine hip or knee replacement. For example, if a patient has tumor around the knee, a knee replacement is where you just resurface the knee. I mean, the joints are resurfaced and you put an implant. But in cancer, we do not remove only the joint. We have to go beyond. Tumor may be involving 5 centimeter of bone, 10 centimeter entire bone. So we remove that part of the bone out of the body, and then there is a defect which we need to reconstruct. Now, the question is, how do you reconstruct? So we may use an implant, or prosthesis, which replaces that part of the bone. So this used to be the conventional way, where we have, this is called tumor prosthesis. So which is a bigger type of implant, which replaces the function of that lost bone, which we have removed, the cancerous part of the bone. Now, what things have evolved? So in biological reconstruction, we use living tissues from the body parts or somewhere,
Okay.
and we reimplant in that position to restore that function, to restore that body part. So it's using a living tissue. Now there are different ways, so we can discuss about it.
Great. That's amazing. And now let's get into the more amazing part, the real sci-fi movie stuff. So cryotherapy.
Yeah.
So it sounds straight out of a James Cameron movie, taking out the bone, dipping it in liquid nitrogen, putting it back, and at minus 190 degree.
Yes.
So walk us through this if we were a 15-year-old, and let us know how you remove a bone, freeze it, and put it back in the patient.
Okay, yeah. So cryotherapy is something very new. It's a niche thing. And I've been using it since almost 9 years, 8 to 9 years. And but it's not devised by me. This was popularized by the Japanese group of surgeons, where they used cryotherapy to kill the cancer cells. Now what are the different options of biological reconstruction? Now I'll just quickly summarize biological reconstructions. So one way is when you have a defect after removing the tumor, you may reconstruct it by using a cadaveric bone graft, which is called allograft, which means you get this from a dead person's body, which is completely clean, sterilized. You get it and you implant in that position. That is called allograft posting. Now we have different techniques. Over the time, because of scarcity of these allografts in India and the cost of procurement from other places and ethical issues to get it from somebody dead body and implanting in your body, we started devising techniques where we can use the same cancerous bone and reimplant it inside the body. I mean, if somebody has cancer of the tibia bone, we kill the cancer cells from the tibia and then we reimplant it. So you need to have a technique which is scientifically proven to kill the cancer cells completely, because you're going to reimplant it. That's the biggest worry everybody has.
Yes, of course.
And we have different techniques to kill those cancer cells. One of the ways is radiation therapy. We used to do it before. We used to cut the bone out of the body, radiate it with high dose of radiation in a single setting. Everything happens while patient is on table. We take it from the operation theater, we send it down to the radiation department in our hospital. They radiate it, and then we bring it back and put it there. So this used to be the traditional way of using, biological reimplantation after sterilization. But this has one disadvantage, that it was completely avascular, which means the blood supply is lost.
Okay, yeah.
The moment you take the bone out of the body, the blood supply is lost. It's
Yes,
like a dead bone. The allografts are also dead bones. We were innovating, is there a way by which we can kill the cancer cells while it is still inside the body? And that's how I came across the literature and the way it was getting popularized, the use of liquid nitrogen. So I'm not sure if you have seen the use of liquid nitrogen, but many times in pubs and bar, they put it in the shots. You see the fumes coming out from your drinks.
Yes.
And even in fairs around, we see that people sell them with a fuming chillness and fumes is there.
That's
So
right.
it has very low boiling temperature, minus 190 degrees centigrade. So what we do in this technique is, rather than taking the bone completely out, we just cut at one end. This is called osteotomy.
Okay.
We cut the bone at one end. We start taking it out of the body while dissecting the blood supply, nerve supply, the entire critical structures are preserved. We do not cut it completely. Then we dip it in liquid nitrogen, which kills all the cells in it, not just the tumor cells, even the normal cells are killed. But the advantage is that we have not taken the bone completely out of the body. It has one end which is still intact. So once we reimplant this in its position, this restores the blood supply, the vascularity. So this bone regrows. It has a huge biological potential of growth, which is lacking with other techniques. So I think this is a game changer. And I have been using it since I started doing it. I have loved this technique. We have seen very good results in terms of outcomes. And I'm a big fan of this biological reconstruction with cryotherapy.
That sounds amazing and very complex at the same time. Just to break down to our listeners. So you have the limb bone patient's limp on your table,
Yeah.
liquid nitrogen pouring in, and it all seems like a race against time. So you explained, but can you just again explain how do you keep the bone alive during all this process?
So I'll just share the examples, some case examples, because many of my friends, when they started doing this, many people had bad results also. Because this technique is really complex. It's not just about reading the books or seeing some video and start doing it. You really need to practice it again and again so that this is a safe procedure.
Yes,
Because
absolutely.
minus 190 degrees is very low temperature. And if you dip your finger in it, even for 3 seconds or 4 seconds, your finger will be totally frozen and it will be dead.
Yes,
So we have to be very careful. So we need to take very, precautions during the surgery intra-operatively. We need to protect the surrounding critical structures like the blood supply, the nerve supply, skin, and we take special precautions with the help of warm sponges, warm clothes, which protect. These are totally sterile in a sterile way. And then we just hang this on a separate table next to our main operating table on a side table so that the things are well protected. They are not damaged. We also need to take care to protect not just from the liquid nitrogen, but the tumor has to be handled in a very sophisticated and a very gentle way so that
Exactly,
it does
yes.
not spill. The margins are totally clear. So this is something probably if it is allowed, then I'll share the video which you can
Yes,
show,
for sure. That would be like
so
very
that people
informative.
can see exactly how it is done.
Yeah. So it sounds very effective, but why is it not being done for all the tumors? Is it like a more aggressive tumor or in a tricky location? What are the limitations for this?
Oh, that's a very fundamental question. So if it is so good, why not do it in every case?
Yes, exactly.
So the challenges are, number one, usually we prefer to do in tumors which are a little away from the joint. If the joint is involved, then we may not be able to dip it completely. And especially if it is a weight-bearing joints, which means in our lower limbs.
Okay.
So whenever the joint is involved, we need to, when we stand, our entire weight comes on that joint. So in that situation, we need to have some prosthesis when it comes to the joint. Those situations we use our conventional way. But whenever the tumor is a little away from the joint, we can cut it from one end, we can protect the blood supply, and we can dip it.
Okay.
The other limitations are when it is a very long segment disease or it is close to your blood vessels where we cannot protect the blood vessels, separate it out. In those situations, it's preferred that you cut it out and then do a replacement with the mega prosthesis.
Okay. Okay. So talking about ECRT, the precision radiation.
Yes.
Taking the radiation out of the body and keeping the bone back. For it seems like taking the bullet out of the firearm, disarming it and putting it back in the.
Yeah.
But it will be useless, the bullet. But here, how do you balance that radiation and killing the cancer cell, but keeping the bone functional?
Wow. So that means you have gone in depth about all these topics.
Yes, I did my homework.
Yeah. So see what happens. Conventionally, radiation is used to treat cancer, and normal dose which body can tolerate is around 1.5 to 2 grays in single fractions. I mean, you when you give radiation, you space it over 4 to 5 weeks or 6 weeks, depending upon the type of tumor.
Yes. Yes.
Now, what we do in ECRT? ECRT is extracorporeal radiotherapy, which means you take the cancerous bone out of the body, give a high dose radiation, and then put it back inside the body.
Okay.
So over the time, we have realized that there is a certain amount of radiation which, if given in a single dose, a high dose, can kill all the cancer cells. But at the same time, we also need to protect the structural strength, the mechanical strength of that bone. That is important. So we have divided around 50 gray of radiation in a single dose. So it is not the same like somebody may question, then why to take it out? Just give entire dose, take the patient to the radiation department, give entire dose and kill it. But 50 gray in a single dose is too high. It's not like a 50 gray which you space over 5 or 6 weeks. A single dose, it can burn everything around. Nothing will survive.
Absolutely.
So body cannot tolerate that dose. So, but when we take it out, we can give 50 gray. This protects the structural strength as well as this kills all the cells it's not just the cancer, the entire cells are dead. When we place it inside the body has a tremendous amount of potential to regenerate. It starts regenerating. I'll just share one simple scenario. I was a trauma surgeon, and I used to see patients from trauma, and if they had a piece of bone lying outside,
Okay.
so we would think 100 times whether or not to put it back inside the body, because that is a completely dead bone.
Yes.
But here we are talking about technique where you are taking the entire bone out. It goes from the operating theater outside, and then you bring it back. So this requires a very strong, teamwork. The most important part is that you need to be aware of the infection control. So we do it in a very sophisticated way, and I think that also I will show you some pics how we do that. So this is a special technique, and unless somebody who has worked and seen how this is done, it cannot be done just like that. You need to learn it and understand the principles, philosophy, and then only do those techniques.
Can't agree more on that. A lot of killing and radiation stuff. So an obvious question, maybe a decade later after all these procedures, can the bone still handle the weight, or is it become fragile like a glass?
So the thing is, as we move into time, the way we go forward, the bone keeps becoming stronger and stronger. It's not like it will become weaker over the time. It is the weakest at the time when we implant it because it's immediate. Over the time, it starts regrowing, the growth starts happening. But like I said, in ECRT, the risks of complications were a little bit higher, say up to 20%, where, like you said, the bone was weak and this used to fracture or some risk of infection like that. So that's how we started evolving and moving towards cryotherapy, liquid nitrogen. Because with liquid nitrogen, we were able to restore this blood supply much early, much quickly.
Of course.
For example, when we do ECRT, normally it takes around 9 to 10 months for patients to start normal walking.
Okay.
But with cryotherapy, probably by 4 to 6 months, my patients are almost walking normally without any support. So that's a very quick, cuts down the time to less than half.
Okay, great stuff. So from all this talk, what I understood is that this is not one surgeon show. So who else is there in the theater with you? Is it like radiation oncologists, engineers?
Orthopedic surgeons are called carpenters commonly. So when people see, they watch us, they say it's a very carpentry job, artistic job. So you're doing, but with the living tissue. So no, it requires a dedicated team. I mean, the people who are working with me, I prefer not to change the teams because every step is crucial. And this starts with my anesthesia team. So they have been handling these type of cases. We need to give proper anesthesia. Patients should be totally comfortable that they undergo this type of procedures because the routine time is somewhere between 3 to 5 hours, depending upon the complexity of the case.
Yes.
So the anesthesia team, my surgical team, I am the head of the surgical procedures. With me, my fellows are there. And the orthopedic surgeons who are getting trained, we have a fellowship training program, who is my first assistant, and dedicated staff nurses who are trained into this. ECRT, when we do, yes, we call our radiation oncology fellows, the colleagues, but they are not scrubbing with us. I mean, they are not into the OT. But the team is ready. When we do these procedures, already we plan the exact measurement, how much bone we are resecting, what time we are going to send it down, and because we need everything planned accordingly so that things go quickly. We don't want to waste time during that. And this takes around 45 minutes to 1 hour when we send it down and then it comes back to us. So we have one of the best radiation machines, which we are able to deliver this dose in 10 minutes or 15 minutes. And the rest is the logistical time to take it from the operation theater down to the department and then bring it back.
Yes. Sounds like an well-orchestrated teamwork.
Yes, it is. Otherwise, it is a very complex situation, which may sound very easy when we listen on the podcast. But it is easy now because we have been doing it for so many years, and
I
the
can
team
only
is,
imagine.
and this is the same team which is trained.
So let's talk about the patients. Beyond the science, the cancer brings in a lot of anxiety to the patient population. So how do you help patients cope up with this psychological impact?
That's one of the biggest thing that we are seeing now, and it's easy to say sitting on this side of the table as a doctor. And I think the crux is we have to be empathetic with what is happening to the other person. We must understand, because sometimes the first word of C, the cancer, is devastating. When it is heard for the first time, people suddenly, the first reaction is that it can't happen to me.
Yes, the denial part.
The denial part, that is the first thing. So I think it is important that they have to be counseled in a very gentle and in a very scientific way. Why this anxiety or depression is because of what they're seeing around. And what they see around is not everything. I mean, there's a lot of misinformation. Many people come to me with Google that this, and you know what Google does? It just tells you the last thing which is going to happen in a cancer. The first part is to create awareness that cancer is curable. You know, in the word cancer, first part is can. There is also
Yes,
can, I
yes.
can. So that is where you can win. So remember that we can win over cancer. It's today, we can cure cancer. I'm talking about bone cancer in more than 75-80% of the cases, which is a very good result. With limb preservation. Limb preservation can be done in more than 95% of the cases. So understanding the disease, I tell them just read about it. We also have psychological counselors who counsels them. And once they are aware that this is a curable thing, limb can be saved, this relieves major part of the anxiety that they have. That the first anxiety is that we have to lose the limb. So that has to be removed. Once they know that they are going to be back to their normal life after the surgery and after the treatment, they are very much into it, and majority of them take it in a positive way.
Great. That's truly inspirational as well. So now, time for a controversial question.
Yeah.
We have seen a lot of interest in the alternative therapies, especially in cancer treatment segment. Dr. Verma, where do you draw the line between, you are going to ensure that the patient is going to get the evidence-based care, at the same time you are respecting their choice?
So I know this podcast is going to be projected globally. So that's why I'll make a disclaimer. This is my personal opinion, and this is the opinion based on the scientific evidence, and which is that, the way we treat a cancer, the most important part is the time. Early diagnosis and treatment, that is most important.
Yes.
So whenever I see a patient, and many a times because of wrong marketing or somebody's alternative therapy, they say that we can cure cancer. These are not the right thing to do, because the current evidence has shown that cancer can be curable with proper treatment. We have surgery, we have radiation or medical management with chemotherapy, immunotherapy, etc. So timing is crucial.
Yes, of course.
Cancer never stops. It keeps dividing if you don't treat it. It keeps growing. And the best results are when it is operated or when it is treated in early stages. Mm-hmm. So if we look out for alternative therapies, and you may see anecdotal cases once in a while that somebody got cured with this or that. Those are very anecdotal cases, and that depends upon the biology of the tumor. We never want to miss out that golden time when the disease is in its early stage. If we miss that and the tumor starts moving to the other part, which is called metastasis, leave the primary site and move to other part, then it becomes late. Of course, still we can cure them, but the success rate comes down. So it's very, very important that we treat it on the lines of treatment which are evidence-based, which has a long history. Now we have more than 50, 70 years of history, all the literature is there, which has shown that chemotherapy treats. The biggest worry is people say, I will not tolerate chemotherapy.
Yes.
This is what they hear from, it's hearsay, what they have seen in movies where they see the end stage, a person in the terminal stage. They do not see things which completely gets cured. But we are sitting in a position where we have such a large database where we see that almost 75-80% people get cured with cancer. That's a very positive thing.
Yes. Okay. Now let's talk about the healthcare in India. We're seeing more patients coming to India for the bone cancer treatment, especially. What makes India stands out in this field?
Wow, nice question. So I will say it not just because I'm in India and I'm practicing here, but I will say it with my experience of so many of my patients. I think I've treated patients from over 40 countries. They have come to
That's
me
great.
for treatment of bone cancer, especially for limb-saving surgeries. And you know, the best part, the treatment available in India is, it is timely possible to start the treatment. Second, the quality of treatment in terms of skilled manpower, in terms of technological advances. And third, I'll not say the word cheap, but it is very much affordable. Affordable is
right.
the right word. So I'll just go a little bit into the depth of these things.
Of course.
Why I say timely? You know, one of my patient, he is in US. So he had a head injury, just simply knocked his head a bit of unconsciousness. And when he went to the treatment, for the opinion from the doctor, he was given a time of 2 to 3 weeks to get the CT scan done for his head, to look out for the brain injury. And then when he did it, can I quote prices also?
Yes, I think it's fine.
So he was quoted for $12,000 and he had to pay some 4,000 as a co-pay. So, you know, he said, in that money, I can travel back to India. He's an Indian. I can travel back to India. And you know, if you come in India, the best part is there is not much of a waiting time because we have so many healthcare services, so many facilities. If I want to get an MRI done today, I can get it done today.
Yes,
if I want it tomorrow, I can get it tomorrow. CT scan, MRI, PET CT scan. So this makes it very much a timely intervention, which is possible in India.
That's absolutely right. Yeah.
The waiting list, of course, there are waiting lists, but you can do this within probably 3 to 4 days. And we have all the latest technologies like computer navigation. We have 3D printed ZIGS implants, which are all available in India. We have robotics, whether it's surgical oncology robots or the different robots that we use in joint replacements. That is all available here and very much affordable. Can I quote something about the cost also of the implants?
Yeah, that's
Yeah.
okay.
So, you know, the same cost, the implants, I will not name the company, but for limb saving surgery, the same implant cost around $50,000 in US, and the same cost in India is around $7,000 to $8,000.
That's a huge difference.
That's
Of
a
course,
huge
yes.
difference. And the best part is the India now is becoming a medical destination for all this treatment because there is something called Make in India. We are relying on the indigenous technology to develop these implants, which has bring down the cost to almost 1/10 of what we used to get it before.
Okay.
So I'm not talking something from way behind, but I'm talking from my experience when I started my practice. The same implant I'm using now at half the price. So a lot of things have changed, and that's why we are seeing more and more people traveling to India as a preferred destination.
That's a lot of advantage as you put it in that way. But what are the challenges the international patients face when they come to India, if there is any, and how do you tackle them? How do you deal with them?
So I think the biggest challenge is that the mindset that, the overall picture that media has created over the last so many years, that everybody thinks that India is still a developing country or it does not have all those medical facilities. So there is a big mindset of coming to India for treatment. But once they come, like just last month, we had a meeting where 8 ortho-onco surgeons were from Canada, they were from Germany and UK, they were there in India for this conference. And when they saw it, they asked me a very, very funny question. Where is the cow on the road? I'm not seeing any cow.
That's a very common question, yes.
Yeah, so the projection that is presented outside for last so many years has been that India is a developing country and you don't see roads, you don't see healthcare facilities. So that is all gone. So now in 2025, we have one of the best infrastructure facilities with all the latest technology and equipments. The other challenges that comes is about, I think, what people come with is about their accommodation, where they're going to stay, and the follow-ups, how we are going to do the follow-ups. So we have devised our own ways to deal with it. For example, like somebody who's traveling from GCC countries or say some Africa. So we have a dedicated team of international patient services. And we have now colonies around the hospital where especially the international patients who travel down, they can stay there, where the food is according to them, different types of food. They have even Turkish foods, with continental foods. So, especially many people come from CIS countries. So the food, everything is according to their own taste and masala, the spices that they use.
Yes.
So that is one of the biggest thing that you need some good food after recovery. That's
Yes, that's
important.
most important.
And the third and the most challenging part is a good follow-up, because I may operate, but again, to get a good result, they need to be under follow-up. So I have preferred to do tie-up with the doctors who are seeing the patient primarily there. We have a good communication system. We can do WhatsApp, we can do mails, and we can be in touch. Many patients, I write all the documents, send them back to their primary team, and we are in touch, the primary team, and we are in touch so that the later part of, say, chemotherapy, that they can get done in their country. They may not travel here, they may not stay in India for 3 or 4 months for entire treatment, but they may come up for the critical aspects like surgery. Then they'll go back and complete their chemotherapy under the primary care team.
Yes, that's understood. So let's focus back on your specialty. So the economically disadvantaged people, can they get access to the advanced limb saving surgery like cryotherapy and ECRT?
Definitely. So see, one thing is about the cost and other things, but there's something beyond it, and that's a humanity. One philosophy I have, that I have never turned down any patient because of the cost.
Okay,
Be
that's
it
good.
domestic patient, international patient, we have devised different ways. For Indian patients who come, there are many. India still has a significant number of people who may be below the economic, they fall into the economically weaker section. But for that one, I travel to different parts of the country as well. I travel to more than 1,000 kilometers, where there are different trust hospitals where we perform these surgeries free of cost in different type of government schemes where this is possible. Number two, we have NGOs who help them contribute, generate funds, because majority of the times what happens, before surgery, we give chemotherapy in cancer, osteosarcoma or Ewing sarcoma. So they have certain time period of 2 months or 2.5 months. So we can start generating funds if somebody is totally non-affordable. And we have some special discounted packages also. If somebody is short of it, then we can give discounts, or I may cut down on my part to make this affordable for the patients. And whether it is ECRT or cryotherapy, in fact, these techniques, the biological techniques, are much more economical than using a megaprosthesis.
Oh, okay.
Because we are avoiding a megaprosthesis.
Yes,
We are
totally.
preserving the same bone we are reimplanting. So this makes it very much into that affordable range.
So, Dr. Verma, one question from the audience part as well. Is this bone cancer preventable?
Yeah, so this is everybody asks, and this question people ask once somebody is diagnosed in their family with bone cancer.
Yes, exactly.
So, let me take it in a very simple way. This will bring up the question, what causes cancer actually? So we must understand that there are two aspects. One which is happening internally, that is a genetic mutation. The other part is external factors. Fortunately or unfortunately, bone cancer, which is called sarcoma, they do not have much of external factors, because if you see, like oral cancer, like tobacco, alcohol, people working in dye industry or some chemical industry, they are at a higher risk of getting cancer because of exposure to chemicals. Somebody who is working in a radiation industry, even doctors are exposed to
Yes,
radiation
of
in the operation theaters and in the
The
radiology
radiology.
department. So those are some risk factors which are external. But the majority component is because of the genetic mutation that has happened inside the body.
Yes.
And we see these cases primarily in children, adolescents, and they do not have any external factors. It is primarily the mutation. So currently for bone cancer, there is no prevention, but the only way is to identify the symptoms which I discussed. So any symptom, please visit your doctor for early diagnosis so that treatment can be initiated and things can be cured.
Yes, time is of the essence. I can give you that.
Yes.
Okay, Dr. Verma. So, if you could leave our listeners with one message about bone cancers today, what would it be?
Yeah, one message is that don't panic when you hear that somebody is diagnosed with bone cancer. Treatment is very much possible. We can cure the cancer completely. and we can do limb-saving surgery in more than 90-95% of the cases. Early detection and timely treatment is the key to success. So consult your specialist for best outcomes.
So today, we have learned that bone cancer doesn't always have to mean amputation, that cutting-edge treatments are available right here in India. And early detection can save lives and limbs. Share this knowledge so that someone can recognize the symptoms early and can prevent amputation and go for a salvage therapy. So I'm your host, Dr. Mohammed Afsal, reminding you that in cancer therapy today, it's not just about saving lives, it's about getting a better quality of life. Until we meet next time, stay informed and stay hopeful. Thank you.